and his crew. I thank Société Ivoirienne de Chirurgie Congress and WFNS Spine Committee invited us to give you some insights about the spine surgery. My special interest is spine biomechanics for a long time, and first I will introduce two short presentations regarding spinal biomechanics. As a surgeon, maybe you may wonder, biomechanics is a basic science. As a surgeon, do I need that kind of tool? My presentation will not be about some theoretical text knowledge, but some insights, how you apply biomechanics principles to your surgery. Definitions. Biomechanics means the study or discipline of the mechanical laws relating to the movement or structure of the living organisms. It is subdivided to disciplines, dynamics and statics, and dynamics also subdivided to kinetics and kinematics, which is important for spine also. Kinetics mainly focus on cause of the motion, that means forces, load. And kinematics does not interest in load, but it is related with motion, description of the motion, including displacement, velocity, and acceleration. Spinal column is the backbone of the body. It has three main functions. It bears load, it supplies mobility to all the body, and it protects neural structures. And it is heavily a physical organ, governed by physical laws. In ideal bipedal posture of the human, there is minimum muscle construction and energy expenditure, and there is minimum stress to joints. To achieve that, spine has 4 curvatures, as you know. Thoracic and sacral kyphosis, 2 of the curvatures, are primary curvatures. Because of the settled posture, that spine, vertebral bodies are thinner in the anterior and thicker at the posterior. So due to the shape of the vertebral body, we have kyphosis. But then we have cervical and lumbar lordosis after we start to sit and erect posture. So this curvature, lordosis, is due to the disc shape. Not the body shape, but the disc shape. And as you know, the discs are degenerated with age. So the result is increased kyphosis and loss of lordosis. This is a natural aging process. So we lost some of the curvatures by time. Aging is kyphogenic due to anterior collapsing disc, all the spine areas, and also there is some compression fractures due to osteoporosis, especially in the women. All over, they cause kyphogenic posture. And this is Konov's economy of Dubosek. He said that we spend least energy at the erect posture at the green line. If we stand like that, we spend much less energy. But if we have some postural problems like kyphosis, we start to get out of the red area. And out of the red area, we need some external support to be erect. If you want to be erect posture, in an erect posture, like that woman, you have muscle tiredness and pain because of your posture. That's why we need some normative values. We have kyphosis and lordosis values, also some spinopelvic parameters to describe what is the ideal position. If you don't obey that rules that hints your surgery, your results will be suboptimal. There is pelvic tilt, sacral slope, and pelvic incidence. I recommend you study all of them if you don't know them yet. Very deeply. I will talk about some properties of the spinal structures because it affects biomechanics of the spine. Of course, vertebra, intervertebral discs, ligaments, rib cage, spinal musculature affect spinal diseases, and all of them should be studied by quantitative anatomy, physical properties, and functional biomechanics. Maybe we need 10 lectures to cover all of them. So I will just give some small examples how they affect our surgery. As you know, much of the load is carried by the vertebral body, and facet joints carries less load. This depends on your posture and also the region, on cervical, thoracic, and lumbar. And trabecular architecture follows some patterns, as you see. Trabecular patterns is weaker in the anterior and superior and inferior. It is moderate at the superior, at the yellow yellow square here, and it is strongest here. So that's why we see a lot of fractures in the anterior superior part of the vertebral body. So this is just one example how biomechanics related with clinics. And we have 23 discs through C23 to L5S1. These are gel-like nucleus pulposus and layered annulus fibrosus. It is supplied by not arteries. Arterial supply is much less, and it is at the periphery. It is supplied by the fluid exchange into and out of the disc that provides nutrition. That's why degeneration starts at very early, second decade of the life. Degeneration starts because of the lack of vessels. And ligaments, they stabilize, they guide the motion, and they supply proprioception to the spinal movements. And their location affects very much their strength. I will show you later how they affect differently regarding their location. And rib cage. Rib cage restricts movements and contributes to the extra stabilization of the thoracic region. Some says that if you divide spinal column 3, as Dennis model, 3-column model, you can say 4th column in the thoracic area. That's why that area is much resistance to some trauma. And spinal musculature is very important for stability. As you see at the right, here below, we see a lot of time in our patients. These patients have lost a lot of muscles, and this is negatively affects spinal stability. I will briefly touch the biomechanics of the spine, level by level. I will mention about movements, loading, deformation, and stability issues very briefly. Spine has studied in 3 planes, and each of the plane has 2 types of motions. So totally we have 6 kinds of motions. As you see from the anterior side, we have lateral translation, lateral bending, axial translation, compression or tensile strength, and axial rotation. And we have AP translation and flexion extension. All of that are spinal movements. Basic building of the spine is spinal functional unit, described by Junkens. It is constituted by 2 adjacent vertebrae, intervertebral disc, 2 adjacent joints, and spinal ligaments. Why this is important? Because it mimics all the spinal motions. If you understand this motion segment, you can apply that knowledge to hold the spine. And in the functional unit, there is an axis of rotation. Axis of rotation means when you make, for example, a flexion extension, some point in the functional unit does not move. All of the points in the anterior and posterior parts
are moved somehow, and some point it is different in every region and every patient, and it is continuously changed. So we say it axis of rotation or instantaneous axis of rotation. Why this is important? Because the forces are affected by the distance to the axis of rotation. If you apply a posterior compression to the spinal process, it will apply much more strength for extension. But if you apply that force to the facet joints, you will have less movement. This is because of the distance from instantaneous axis of rotation is much higher for the spinal process. Moment means tendency of a force to twist or rotate an object. For example, if you press the anterior to vertebral body, you will see a bending moment. It will be a flexion. We say it moment. And this is the most important formula of the spinal biomechanics. Moment equals to force times distance. That means when you apply force, and you multiply it with the distance to the instantaneous axis of rotation from here to here, you will have the moment amount. And because of that, like Archimedes says, that guy has equal strength in that machine to that guy because of the distance and force issue. And because of that, going back to the ligaments, one of the most powerful ligaments, although they are anatomically is not powerful, they are important in biomechanics. The ligaments far away from the instantaneous axis of rotation. That's why when you have a flexion trauma like that, you see a small compression, a compression flexion trauma like that, you will see a spinal process fracture or supraspinal ligament disruption at very posterior because moments are much higher there. And if you have a kyphosis, increase in kyphosis, your distance will be increased. And if that increase, your bending moment increase. So when a deformity begins, it causes another deformity because of the increased distance of to the instantaneous axis of rotation. Deformity causes or begets further deformity every time. And that's why, what do you think? Which one is best to support that spine? A, B, or C? A is best. Why? Because it is farthest from the instantaneous axis of rotation and its impact is much higher. Spinal instability can be classified as acute or chronic. This is the most basic but useful classification, I think, of spinal instability. Acute instability could be overt, like that, or limited. Some small disruption of the ligaments, but there is no dislocation. Or it could be degenerative. We say it glacial, like icebergs, slowly moving, or dysfunctional motion segment. It is not seen on the X-rays, but it's detected clinically. Spine needs a flexible stability because of it both supply motion and protection. So we need a flexible stability. For that, spine needs healthy tall discs, elastic ligaments, and muscle support. With degeneration, you lose all of them. There will be collapsed discs, loosened ligaments, and diminished muscle support. As a result, degeneration degenerative changes of the disc cause instability, and instability cause further degenerative changes, as circular visiosus. That is because once a deformity started, it is natural to it progress, and deformity progress. And there is some natural stabilization efforts, as you see from the X-rays. There is traction COURSE at the corners of the vertebral body, and then osteophytosis to limit them. You see, osteophytosis occurs where it is needed. It starts to, it tries to stop the instability. And this is well described by Kirkaldy and Farfan. In early phase, there is abnormal motion, instantaneous axis of rotation change, laxity of the ligaments, and increased range of motion. This is unstable phase. But in the late phase, there is decreased ROM due to osteophytosis and fusion. That means rest stabilization. Nature tried to re-stabilize the spine. So my message for that presentation is, spine is a very physical organ and heavily governed by biomechanical principles. Knowledge of biomechanics is necessary to understand all physiological and pathological processes, and spine surgery and also instrumentation. This is maybe just 1% of spinal biomechanics I would like to convey you. We planning to give all of that curriculum in an online fashion. Indeed, WFNS administration first rejected it, maybe, but we can make it in by time, I hope, before the end of this year in Spine Academy. There will be much more knowledge about that issues. Thank you for your attention.
Thank you, COURSE CUMHUR. You can continue with your basic conductor on biomechanics for spine surgery.